All right. Thank you for joining us today for the value of physical therapy in microgliopathies. Please note we are providing this webinar for educational purposes only. For any treatment decisions, please speak to your treating physician. This webinar was previously recorded and will be available on the GliaConnect website, GliaConnect.org. If there are any questions after the webinar, please direct them to info@GliaConnect.org. So my name is Erin Sullivan. I'm Executive Director of GliaConnect, and it is my pleasure to be with you today and introduce Rich Reed, a physical therapist from Nevada who has worked with neurological patients for many years. Welcome, Rich. We're so glad you're here. If you could give us a little bit of the introduction, tell us who you are, we'd love to hear it.
You got it. Well, first of all, thank you, Erin. Thanks for having me. I am honored that you guys would think of me, and it being a very important topic for families and those who are afflicted with these kinds of diseases. Physical therapy is a very important part of their process, and so I'm glad to be talking about that today. I'll start with a little bit of background on me. I'm a physical therapist. I have been a physical therapist. Well, at my point, we just say well over 20 years. I'm closing in on 30 actually, and I've been in a number of areas. I originally got my master's degree in physical therapy in 1997 at Chapman University in Orange, California. From there, I moved to the Reno area, Reno Tahoe area, to start my career. Continued on to get my doctorate about 10 years ago, and in my career, I've been in quite a few different locations, places in terms of professionally. The demographic of patients that I've worked with is fairly varied. I say I've worked in most areas of physical therapy outside of pediatrics and wounds care. My current practice is primarily geriatrics. I do home health, and I do also personal training in the privately. I work home health for a corporation. The large majority of my patients now are in their 70s, 80s, and 90s, and a variety of either injury, illness, disease process that are going on with them. In terms of neurologic disorders, I have worked with a number of patients over the years with Parkinson's disease, ALS, very related processes to functionally to what we're talking about today with microgliopathies and ALSP.
Absolutely.
And so I hope to bring some light to those things from a physical therapist standpoint, as well as other questions that you have just about general topics and how to care for and navigate systems.
Perfect. Well, it sounds like your expertise is just in line with what we need, and we're so grateful for your time today, sharing your background and your expertise with us. So before we dive into the meat of our conversation, which is going to be focusing on the value and benefit of physical therapy and microgliopathies, I want to take just a moment to define what a microgliopathy is. So microglia are a type of glial cell found in the brain and the central nervous system. And they act as the brain's immune cells, monitoring the environment for signs of damage or infection, and then providing support and protection for the neurons or the nerve cells. Now, microglia play a crucial role in maintaining and supporting brain health. A microgliopathy occurs when microglia are not functioning properly, which can lead to various neurological disorders. And in our case, we represent all primary microgliopathies, which include ALSP, Bandos, and Nasu-Hakola disease. And primary microgliopathies are often caused by genetic mutations. Microgliopathies, when we're looking at what they do to the brain, they damage the white matter of the brain. And the white matter is like the communication network of the brain, coordinating and connecting the various regions of the brain. Microgliopathies also cause neuronal or nerve death. The damage to the white matter and the death of the nerves leads to a whole array of symptoms that can manifest as cognitive or thinking changes, behavioral changes, and then motor and movement disturbances. And it's because of these motor disturbances that many of our patients end up utilizing the expertise of physical therapists. So that's how I kind of want to transition into what is a physical therapist? What's the intro and overview of what a physical therapist is and what you all do?
But perfect, perfect introduction, and much better in the science of things than I would be able to give. Thanks, Erin. So what's physical therapy? Boiling it all the way down to the very nuts and bolts is we're experts in mobility. And that can be anything from an orthopedic injury, which probably many of us have the most knowledge of physical therapy, where there's an injury and we help people rehabilitate from that and gain their mobility back, if you will. And lesser known areas of physical therapy are in the neurologic area, or where people have a disease process that goes on, and it affects their motor control, and we help in assessing what's going on with their ability to move. That might be generalized weakness, but it's off most of the time much more profound and deeper root causes than that. And than just weakness. When we talk about the things that physical therapy assess, we start to assess deeper. Why are we having difficulties with movement? And that can be anything from movement, from why are we having difficulties with walking, why are we having difficulties with balance, to why are we having difficulty with being able to feed ourselves, or to the wide range of mobility concerns that physical therapists will look at, depending on the on the condition of the patient.
Okay. And then what would you say is kind of like the goal of physical therapy, especially in context of these neurological diseases that we know are progressive and they're not going to get better, but that there's still value for physical therapy in that context?
Precisely. And this is a great question. Um, it, what do we want to do in physical therapy? Um, when we look at neurodegenerative diseases, and as much as much as we can look at and empathize that the goal of many patients that go to physical therapy are to be restorative, and I want to regain my ability to walk or run or something like that. In neurodegenerative diseases, what we're primarily looking at for physical therapy is how can we best improve that person's independence. Most of these folks have lost, when they get to physical therapy, have lost a degree of independence, either independence in walking, independence in getting out of bed, independence in getting to the toilet, and, that variety of things. So how can we best preserve their independence or give them back some of that independence? Certainly. How can we? So when I say independence, it's function. You'll hear function a lot of the time. So how do I function in getting from one place to the other? That sort of thing, and realizing that the trajectory of neurodegenerative disease is a downward process. What we're looking to do in physical therapy is to help minimize the decline or slow the decline as much as we possibly can, and through whatever treatment techniques that we give, through whatever education that we can give to the patients. So it's about again, down to the main core. How can we maintain function as long as possible, maintain independence as long as possible, and in that, give these folks the best quality of life that they can have from that perspective.
Yeah. As I'm listening to you talk, this so resonates with my experience with my own family, but then what I'm seeing in our other patients. And you mentioned one of the things that you mentioned in there that I want to touch on is education. And certainly you will be working on educating the patients, but we would be remiss in not mentioning another very important person in this process, which is the caregiver. And I imagine that you do a lot of education also with the caregiver during your sessions.
You took the words out of my mouth. Yeah, so the family circle, including professional caregivers, including obviously folks that live, family that live with the patient or nearby. Education in the process to them, so that they can help take care of not just to help to take care of the person, but help again to extend that ability for the person to help take care of themselves as well, the person involved. And so education can be the entire family circle.
Fabulous. And I just love how you mentioned also the professional caregivers. I think it's important to remember that anybody that, well, for what I'm hearing, is that anybody that's going to be helping with that patient, whether it's professional, whether it's family, can definitely utilize physical therapists as resources to educate themselves on how to best care for and help maintain that functionality for as long as possible.
Absolutely. So there are multiple people involved there, and that we're concerned about their well-being as well.
Yeah.
The well-being of the caregiver is often overlooked, and the things physical therapy can provide for that are simple as what we consider simple, our day-to-day biomechanics on how you help a person transfer, or how to
Yes.
help a person move, uh,
Yes.
and realizing that this can be very physically taxing. So obviously
Hmm.
emotionally taxing. It can be very physically taxing, which creates a cycle of um, it creates a cycle that is very difficult to sometimes deal with, and just finding ways to make it physically easier can help with also the emotional part of that as well. And so that's where, again, the term physical therapy, we we can help show a person how to much more easily help another person without breaking their own body down. Um, uh,
Yeah.
and
Super important point. I mean, all of us who have experienced caregiving, we definitely resonate with that. Okay, so I think we're going to be talking more about this as we get into some of our questions, but
mhm,
I want to take maybe a little bit of a step back here. Um, so many physical therapists are not specifically trained for ALSP. And of
right,
course, we do have to encourage our patients to find local physical therapists to provide care. So it can cause quite a bit of a challenge for our patients who are attempting to find this care, but struggling to find a therapist that can, have a grasp of the situation. So when meeting with a local physical therapist, what do you think is important to share about the disease? What as a physical therapist do you find most helpful when seeking to understand how best to build a care plan for a patient?
Great question. I'm glad we took a step back and started looking at this because imagine anybody that's watching this is looking for, has run into the physical therapists often are not specifically trained in things like ALSP. Now, that said, all therapists have had training in neurodegenerative disorders. And I would tell you that most with any experience, most even coming out of school, have some hands-on experience with neurodegenerative disease. But of course, as practice in any profession works, is the more you see, the more you do, the more expert you get at. Of course, ALSP is and all microgliopathies are rare enough that I would tend to say most therapists have not seen these things specifically many times over their career. Again, I've been in career for a long time, and when we met each other from through a friend of mine who was through a friend of mine's family who was afflicted with ALSP. I knew him. I first knew him when he and I coached soccer together. He was a professional soccer player. Do you mind me sharing this?
No, absolutely.
He was
Absolutely great.
a professional soccer player. He and I coached soccer. He was a very healthy young man in his early 40s, and a good friend of mine. I realized that he was having some difficulties with his balance. He actually came to me. He had moved away. We frequently talked, and he told me he was having some difficulties with balance. I came to see him and realized fairly quickly that it was more significant than you've just got some weakness in your leg, as time went on, and I saw that there was some progression to this, and he was starting to seek professional help. My first thoughts were that he had ALS, so it's a very similar functionally, and from a trajectory of disease process is very similar. So in that process, it took quite some time for him to be, as I understand, most with microgliopathies, for him to be accurately diagnosed. It was not ALS, and so in that process, and I'll get back to the question is how do we know that a physical therapist, how do we know what they know? Well, you can understand that they'll know neurodegenerative disease. How do I find a physical therapist? If you're seeking out a physical therapist, or if your physicians have recommended physical therapy, the first thing I would do is call around physical therapy offices and see, do you have somebody that specializes in neurologic disease? Parkinson's, ALS are much more common. Yes. And the carryover of practice functionally is similar from what I've seen, and so they would have a much deeper knowledge base of variety of tools, as we say, to yes. help you and help the client. So somebody that specializes or focuses on neurologic disorders. Now, our association, Physical Therapy Association, has specialists in certain areas, orthopedic certified specialists. There is a neuro certified specialist. Then if you can find a neuro certified specialist, and I live in a town of 600,000 people, and as far as I know, we might have 5, maybe neuro certified specialists. But that's somebody who has basically focused their career on neurologic disease. Now, you may not be able to find somebody that focused. At the same time, um, um, most that have worked in the area of neurologic disorder and disease have focused their career on that area if you ask. And so even just asking the front office, do you have somebody who focuses on this? And that person will see in their day, they'll see patients with stroke, brain injury, ALS, Parkinson's disease, and any other variety of neurologic disorder. But all again, they'll have, that person would have a bigger tool bag to work from if you can seek that out.
That's great input. So let's say caregiver or patient calls around, and they can maybe find someone in their community that sees the neuro patients, but it's not their specialty, right? It's not the certified specialist. What resources would you think they would find especially helpful when starting to treat someone with a microgliopathy?
Good follow-up question there. So the first thing when you meet your physical therapist, I always recommend that primary caregiver at least, or primary family member, is present at the initial evaluation at a minimum.
Mm-hmm.
So you'll be set up with an initial evaluation. You'll meet the therapist, and it would be good for you to come prepared with information on what ALSP is. It's a neurodegenerative disorder, and that will give the therapist enough to work with. And there are and most therapists have in their ability to, obviously we all do, to research and so forth. We have an association, the American Physical Therapy Association, that has and it has bountiful information online for both professionally for therapists and for family members and patients. And so those would be sort of resources that they can refer the physical therapist to if that comes up. But certainly I would come day one prepared for giving them some information on ALSP. That's a neurodegenerative disorder. It is and very similar to ALS.
Okay.
More so than Parkinson's. Which gives us an idea. And then you would, what I would want to know, and the therapist would, in the interview, most of the time ask these questions, but it's always good to come with the bullet point of, these are the things I want covered. What was the initiation? When was the initiation of the, when were the initiation of symptoms? When was it diagnosed? What has been done to date in terms of procedures, surgeries, that sort of thing.
Any type of intervention that has been done.
Thank you. Any type of intervention that has happened, and then the trajectory of the client or patient's function. What has that looked like? Did they go from suddenly being able to play soccer to 3 months later falling down every day? What's the trajectory? And it's different for everybody. And then what has the last, I like to ask, what's the last 3 months look like? What's the last 1 month look like? Have there been any incidents, falls that precipitated this referral to physical therapy? Has there been anything more acute that's been going on? So we want to know the chronicity of the disease process and any acuity of anything else as well. All right. So and then from there we want to say, okay, what's the day-to-day look like for you? What does it look like from the time you wake up in the morning Do you need help getting out of bed? Do you need help getting moving in bed? Do you it can be anything. So what are you having difficulties with? I guess I would start with that
Okay.
question as a physical therapist. But we want to know what the day-to-day struggles are for that patient physically,
Okay.
and so get an idea of what that looks like today. But I also want to know an idea of what that looked like a month ago. So you're
Okay.
telling me today he's in a wheelchair, but a month ago he was walking without a walker.
Hmm.
That gives me an idea that that gives me a different idea of the things that I can do to help
I
uh,
see.
in terms of, can we do a little bit of restorative rehabilitative therapy to help get back to a month ago's function? Is that
Mhm.
feasible? Um, and or are we at a point where we need to look at, we need to look at things that are to keep stability and to maintain? Are we there? And that's a fluid thing. Can we find some rehabilitation within the maintaining maintenance process too?
So all of this information kind of helps you filter through and understand what's happening so that you can set appropriate goals to be working on.
Yes. Yeah, absolutely. Absolutely.
Perfect.
And then we prioritize these goals with you, the client, and say, okay, what do you want to? I think this is the most important. First of all, safety. Second of all, independence and maintenance. What do you feel is most important to you? Setting those goals.
So that leads me into my next question. So
Mhm.
a lot of times when we think of physical therapy, we think of symptom improvement, even in things like stroke patients, traumatic brain injury. We talk about symptom improvement, but we do understand, and what we see and what we know is that in neurodegenerative diseases, the symptoms will progress. They're going to get worse, even with therapy. And so, with that in mind, what minds, so this is kind of a two prong. So, what mindset should patients and caregivers have when participating in physical therapy? And on the other side of that coin, what mindset should a physical therapist have when treating a patient with a neurodegenerative disease?
Again, excellent questions. And these are ones sometimes, these are things that are sometimes difficult, probably professionally for therapists as well as family members to understand, is that uh, the patient's function is not going to get better over time, over the long time. And so we have to set our the mindset is, how can I best slow the decline that I know is going to happen, that I unfortunately know is going to happen. There's going to be decline, but how can I slow that down, and how can I uh, give us being the family and the patient the best quality of life during this process? Uh, and and um, and that's kind of the mindset that I would hope that we can give to the client, to the patient, and to the professional, the physical therapist.
So there's two words, and I think they kind of, in my mind, sum up what is the mindset. Safety. How do we keep the patient
How do we keep the patient safe
and the caregiver safe?
and the caregiver safe?
And quality of life. How do we maintain for
Yep.
as long as possible the best quality of life, again, for both the patient and the caregiver?
Yes, absolutely, absolutely.
Okay.
Yep.
So I love that. I think that's like the perfect, it's super simple, but it gets to the heart of the matter of what the ultimate goal of physical therapy is. what barriers or challenges uh, do you expect when treating someone with a neurodegenerative disease?
Um, a lot of times it's the biggest difficulty is emotionally and from a mindset of I want to get better, I want to walk again, when walking is clearly not something that that patient is going to be able to do again. Um, so getting through that and understanding that um, that the work that you're putting in terms of exercise or in terms of the things that you're doing are not to get somebody to climb that mountain again. They are to help them from sliding down further and faster, and to help them, frankly, um, psychologically be able to uh, handle the disease process better themselves and the caregivers better themselves. Um, so those are the sort of biggest barriers. Physically, there's some barriers. Absolutely, there are some caregivers that just physically cannot do some things, and so we have to be realistic about that. And if I mean, I have 90-year-old wives trying to take care of their 93-year-old husbands physically, and realizing that that's not safe and they can't do that, and getting an understanding that this isn't something that's safe for you. So instead of at home you trying to walk him, which is unsafe for both of you, maybe the my advice would be maybe the safe thing would be to be in a wheelchair and do exercises from there or activities from there that you can find, um,
Yeah.
as a thing. Another barrier that that I didn't mention that I'm kind of thinking about now is another barrier is a conflict between what the caregiver wants and what the client wants, and that's sometimes just um, uh, interpersonal sort of things, but oftentimes friends and family will be like, well, just try harder, work harder, and imagine that being you, the person that's being told you're not working hard enough, is often how that is received, and it's meant in almost every case as trying to be encouraging.
Yeah.
But I've seen that oftentimes that sort of mentality, that military, you got to do 10 reps, you got to do if you don't do your walking today, oftentimes that becomes deflating a little bit. And so gauging that, understanding that, okay, I'm pushing a little too hard. Um, Also realizing that particularly in this area of um, microgliopathies, that and neurodegenerative disease altogether, is that um, tolerance to act that tolerance to activity is extremely limited.
Yes.
If you
Great
can
point.
imagine yourself not sleeping for 72 hours and then being asked to go out and run a mile.
Yeah.
Oftentimes, exercise therapy can be that to a patient. So we have to understand that the barrier there is actual, it's a real barrier. And then
Yes.
we have to, and then we have to recognize that and cater our activities around their ability to tolerate them.
Yeah. I think that's a brilliant point that will absolutely resonate with both our patients and our caregivers, because it's what the patients feel and it's what the caregivers observe and perceive. And I think this brings up, ancillary to another kind of barrier, which is not only do you have this physical decline, which can impede that activity, but also the cognitive decline is going to be creating challenges potentially in like limiting the ability to learn new things, or understand certain directions.
Yeah, yeah, absolutely. So the cognitive behavioral changes that occur have to be recognized as well. And just as you said, I mean, those have changes in assessing on a regular basis. And this is one of kind of gets to the topic of why physical therapy. Um, Physical therapist is trained at assessing those changes as well and understanding that the program that the patient is on may need to be adapted, because this is a digression, and this is part of the disease process. And so understanding that those things are there, um, um, communication, cognitive understanding of instructions, and be able to follow through with instructions will change.
Yes.
And so how can we see that and give a way for the client and the caregivers to recognize and be able to deal with that. Yeah.
Yeah. So something came to mind as we're talking about this, and it's all the things that you as a physical therapist and even the caregiver has to manage, and it's all of this, modifications and adaptability. And but one place where the rubber really hits the road on this are insurance challenges. And we know in our community that that is in many cases a big barrier to receiving the care, the maintenance care, I'll call it the maintenance care that our patients need. Um, and ha Are there ways in which the therapist and then the caregiver can kind of work together to overcome some of those challenges that they might run into with the insurance?
Absolutely. And a really good question that we as physical therapists struggle with all the time are insurance limitations and what is maintenance care. That's become more common terminology here of late. I would say of late, the last 5 to 10 years, maintenance care and physical therapy, and it's been one that's really um, been challenging for therapists, because we see that families see that we have value in helping the patient and the family. Um, but the insurance company feels like there's not a understanding of that value, and so the things that we can do for caregivers are are primary family members, caregivers are the advocates, obviously 99% of the time for these
Mhm.
patients. And so being the advocate here is really, really important. When you feel that you're being cut off from a benefit of physical therapy, that you feel is still beneficial to you, the patient, um, how do you advocate for that? And oftentimes you'll run into a black and white. We have no more visits that that you can pay for. So is there a way to navigate around that? Is there a way to talk to the physical therapist and say, hey, can we look at changing the goals, um, and decreasing the goals? So because often physical therapists are we're looking at rehabilitation or improvement trajectory, even within a stable um, uh, a time when somebody's function is stable. And talking to them about, well, what does maintenance care look like? It's Even though it's become more common, maintenance care and physical therapy is, I would say, is not common. So there
Okay.
is, and every insurance is different. Um,
Yes.
I'll speak for Medicare. because I know that a little bit better.
Yeah.
Most insurances over time follow Medicare guidelines in many ways. Maintenance care is something that is a qualification for continued physical therapy in these clients with Medicare. And,
Okay.
and so look into that. What is maintenance physical therapy? And so what maintenance physical therapy is it a good time to define that now?
Yeah, great.
So maintenance physical therapy is providing, you have to have a skilled need of physical therapist. In other words, you need the physical therapist not to necessarily do the physical parts of what they're doing, but to assess what changes are going on with the patient, what is their physiologic response to what I'm doing or to what you're doing, and how do we need to adapt an exercise or activity program to handle, to best deal with their physiologic response. And so that takes a skill to be able, the knowledge of a physical therapist to be able to do. So they'll talk about, it's no longer a skilled service. I'm sure you've heard that in nursing and everything. And so it becomes an unskilled service when it's rote, when it is just rote exercise. Okay, we're going to do this exercise 10 times, this exercise 10 times. If anybody can guide the client through it, it is rote exercise that becomes non-skilled.
Okay.
If they're having a negative effect from the exercise, or they're not getting a positive effect from the exercise or activity, then that needs to be assessed as to why, then that's the skill of the physical therapist. And so that's where the skill part comes in, assessing physiologic response, making changes to rote programs in response to that, and so being an advocate for, are these areas that we can look at? And is maintenance therapy an area that we can look at? What is the skilled need here? Well, I'm doing these 10 exercises at home, but something's not, they don't seem to be working or whatever, or whatever. But maintenance therapy is generally less in terms of frequency, how often the patient is seen.
Okay.
But
so maybe if I'm understanding it correctly, maintenance therapy isn't necessarily this, like, we're going once, twice, 3 times a week. It's, we've been doing things at home, we see change, we need a new assessment so that we can make some adaptions, make some modifications, so that we can continue to work with the skill level of our patient at home as we're able.
Absolutely. So continuing on in a way. So again, we're looking at, I want to say another key term when we're trying to qualify somebody for maintenance physical therapy. The first key term is skilled, and I just discussed that. The second key term there is to prevent, I want to get this right, to prevent or slow a likely decline in function. So I need the skill of a physical therapist to prevent or slow the likely decline in function. Okay. So that's the two pieces that are needed for Medicare physical therapy.
Yep.
Maintenance physical therapy.
Okay.
And again, generally that's going to be less frequency, but the physical therapist at that point, you're looking at, there's a lot of education involved there, but there's a reassessment. Is somebody's joint contracture getting more? Oh, a layman wouldn't understand that. And how can we help that? How can we help that their elbow flexion now has gotten to a point, I'll put it in the frame, their elbow flexion has gotten to a point, their inability to move their elbow has gotten to the point where they can't push down and transfer themselves. a layman's not going to be able to understand that that's the reason. So coming back to a physical therapist either weekly or every other week to say, oh, this little change is happening. Is there something that we can do to affect that?
Okay, so now we're gonna take that and we're gonna make just a slight step to
Mhm.
go, and we've talked about this, we're gonna continue to talk about it, but the benefits of physical therapy, and this is just one more that we see later on in disease progression, and I think all of us as caregivers have witnessed this. We see these changes um, that we can't even necessarily describe. We just experience them, and having this maintenance and this kind of um, assessment can help us as the caregiver understand what's happening physiologically, and hopefully with the help of the physical therapist determine solutions to again maintain safety and quality of life to the best of our abilities. Is that kind of a good
I couldn't say it better.
summary of that?
No, that's slowing decline. So what can that mean? It can mean anything from decreasing the rate that somebody's falling. Sometimes we know that somebody's at high risk of falling, um, and how can we decrease? Are they gonna fall? How can we decrease the rate from they're falling 3 times a day to um, once a week, once a month? Can we decrease? Can we make them more safe uh,
Yeah.
in their decline? Slowing the decline, that's a hard one to gauge. It's impossible to gauge. How would I know that I didn't do something if I how do I know how fast they would have declined? Well, we understand. We can see that, and measuring that's a little difficult, but we can say, hey, this person has had 1 fall per month since doing therapy, where they were having
3 a week.
3 falls per week when they
Yeah.
weren't having therapy. That's sort
Yeah.
of,
I got you.
and then and then improving comfort, improving patient mood, quality of life things.
Yeah, and just to kind of round out some of the benefits that we talked about, kind of to reiterate them, we've talked a lot about safety, we've talked a lot about maintenance, we've talked a lot about slowing decline, but you've also, and I really appreciate this, talked about helping, like in all of these things, you're actually helping some of those very hard emotions that our patients and caregivers are undergoing. If we can lessen some of the physical burden, it makes some of that emotional burden um, easier to grapple with as well. And then, of course, education. We've talked a lot about that. It's another fantastic benefit. Okay,
Yeah.
so I want
One
to, oh, go
one
ahead.
thing that I want to add real quick, and I
Yeah.
don't want to interrupt. It just hit my mind. The other thing is prevention of preventable, potentially preventable issues, and the
Yes.
big thing that comes there that comes to mind is skin integrity.
Mm,
Wounds in these clients are can be preventable for the lifespan of the disease in most cases. All right. Not all
yes.
cases, just like anything. And it's certainly in many cases, but I don't want to overstate.
Yeah.
But that's another benefit of physical therapy is understanding if this person is at risk and what are the things that we can do to keep them at least risk. So we talked about falls, but least risk of skin integrity wounds.
Yes.
That's a big and bad. What are the things that we can prevent that we can do to decline to decrease the decline of lung and respiratory issue
Yes.
and concern, because there are exercises and activities that we can do to help expand through expanding the rib cage and doing certain type of breathing techniques, showing you to show certain type of breathing techniques to keep them oxygenated and keeping from potential respiratory problems. So it's not just movement, strength, balance. It also deals with all other systems of the body, the brain. The brain is affected by movement or immobility. Uh,
Hmm.
and we can go, the skin certainly is
Yes.
affected. The heart and lungs
Yeah.
certainly are negatively affected by immobility. So all of those things are other benefits of physical therapy that are a little less under the covers.
That is that is just perfect, and I hope that people listening to this really take that away because a lot and when we talk about this as a whole person, whole body disease. And that's exactly what you're talking about. And when our patients are receiving care, we do want people to understand that it is a whole body, whole person disease, and we want to be proactive where we can to again prevent in as much as we can these some of these issues that you just mentioned and of course others. And so now this is a great segue into my next question. And this is high level and we don't need to dig too deep into this, but what activities or exercises should a physical therapist focus on when treating our patients, and what are there any exercises that should be avoided?
Again, good question. I like the segue. So what's the area of focus? And that really depends client by client by client. I can have a 103-year-old lady one day that is walking around and living in her own home and cooking her own meals.
Yeah.
I can have a 45-year-old client that can't get out of bed by themselves,
Yeah.
can't toilet themselves. And so that really the focus of care is really where's the client. That's best done with the physical therapist, right? That's gonna happen when in that what I told you about the initial evaluation and the initial patient and client interview. Um, what's going to be our focus of care here? And there may be many, and how do we prioritize those and so forth. But that's that can be anything from gait and balance training, which we all think of first in physical therapy, to prevention of skin wounds from immobility in bed or immobility in a wheelchair. So the focus of care can be pretty wide. It just is really client focused there. Does that answer the question?
That does answer the question, I think in the best way that we could
Let me add to that
yeah.
one thing that's specific to neurodegenerative diseases. Fatigue is a big issue
Mhm.
with this group, and and understanding that fatigue is the limiting factor, and that fatigue is generally not going to generally improve
Okay.
um, through doing more exercise. So, so one thing I try to make clear to patients, either in processes like these, are that when we go to the gym, you and I, or a healthy person goes to the gym, or we're told, the common literature is you work out 30 to 60 minutes, 4 to 5 times a week, and that's how you exercise. Well, that's not reasonable. And some physical therapy sessions will not look like, oh, gosh, that wasn't you didn't do a whole lot. There's a reason behind that, because exercise itself can and will fatigue the patient. And so what we don't want to see is this trajectory of I'm working out real hard, I'm exercising real hard, and then they get home and then they're shot for the rest
Yeah.
of the day. That's
Yes.
fair to the patient, and it's not a good either recovery or maintenance process. And so what I tell, I say this on a daily basis. First of all, do a little less than you think you can do
Yeah.
to the patient. We want to do a little less than you think you can do. I know you want to do 100%, but 100% is going to make you worthless for the rest of the day,
Yes.
and probably tomorrow potentially, right?
Yeah.
And
Yes.
so do a little less than you think you can do. And then secondly, chop it up into small bite-sized pieces. Exercises for this population are not intended to be done in one section, 30 to 60 minutes, 4 to 5 times a week.
Okay.
So if you can think of, okay, my goal is 30 minutes of exercise a day. For this population, it should be 5 minutes at a time, 6 times during the day.
Okay.
Can I do this and simple movements so that I'm not exhausting somebody, so that their recovery ability is and time is better, right? Does that?
Rich, I think that is so important, and I'm so grateful you brought that up because it is certainly what we witness in our patients. And I think that advice really hits home and I hope it does hit home to our caregivers and to any of the physical therapists watching this as supremely important to
Yeah,
all of the benefits of physical therapy that we have been talking about. And by not overdoing it, you're only increasing those benefits. And by overdoing it, you can be actually mitigating those benefits.
yeah. And I'm going to go back to an earlier question that you asked on what do I talk to the therapist about first, when I
Yeah.
first. This is this is one of those topics that you talk about, is the fatigue.
Okay. The fatigue.
And 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 then on top of that, the other thing is, don't have an expectation. I shouldn't say don't. I would recommend that we don't have an expectation that the therapist and therapy staff really work the patient hard. You really, that's not good for the patient. And getting the understanding that in many cases, that's not good for their recovery. And getting to just what I was saying, the understanding that we don't want to work so hard at our max capacity like you would exercise, that
Yep.
want to be submaximal. And so a therapy session may not be what you think a therapy session is,
Yeah.
intentionally.
Well, and I
You
think
don't have conflict with the therapist either. Like, you're not
no.
working hard enough,
Yeah.
sort of thing.
Well, I think to round out that thought is so here's something that we observe. So it's not just the physical changes that it is the physical changes that cause some of this fatigue, but it's also those cognitive changes. Just so everybody's on the same page. Part of this disease is like they have to work harder at doing even the most simple tasks. For
Exactly.
us to put on a shirt takes that long and we don't have to think about it. For
Yes.
our patients, it's a whole series of processing that they really struggle with that just wears them down. And what we know in this is that, and what we see in this is that over fatigue actually obviously decreases quality of life, but it also increases the risk of injury as
Everything.
well.
Yep.
And just general as you said, everything. It increases kind of risk of many things.
Absolutely. It increases the risk of, well, safety risk, but certainly.
Safety, yeah. Yeah.
Um, it, it speeds a decline. If I were to, it speeds a decline in function
Yeah.
when you work too hard. You work at your maximum too often.
So this leads to a question that we get pretty often in our community, which is how do we know, how does a patient or a caregiver know when it's time to stop physical therapy? When it's time to stop pursuing that avenue?
When is it time to stop? I see people through their lifetime.
Okay.
I don't see them often. Sometimes I'll see them once a week or once a month even. Um, I don't think, well, the time to stop, I guess, is when the client wants to stop, or they're frustrated, or they become to the point where they're frustrated that they're not getting what they want out of therapy. Um, so I in many cases, therapy can go on, from my perspective, forever. We can always give comfort. We can always give, we can always help with quality of life at whatever stage we're at. Um, we can always help, and some of this is in education, some of this is in physical touch. We can always help with pain. We can always help with skin integrity. We can often help with respiratory condition, stiffness, and mobility. And those things came, but we can always help with that. So is there a time to stop PT? I don't feel there is in most cases.
And
Um,
maybe this goes back, Rich, maybe this goes back to kind of changing that mindset. And that's when we bring in that maintenance, that
yeah,
maintenance.
yeah,
And
yeah,
that's maybe how we think about it. And even maybe if we don't see, I'm just kind of talking out loud here, but maybe if we don't, maybe it kind of shifts, and the most benefit of this time with a physical therapist is actually for education for the caregiver. And
absolutely.
maybe that becomes a switch that we see.
Yeah. And so that kind of gets to sort of one of the other primary points that I want to get across is the most important time for physical therapy is not the time you're with the physical therapist. It's
Mm.
the rest of the time. And what I mean by that when I say that, and I say it often, is the physical therapist will benefit you and hopefully benefit you greatly the 1 or 2 times a week that you're seeing them during the 6 or 8 or 12 weeks that you do see them, or years that you see them.
Mhm.
But if you're not able to come up with the therapist a program that you can do on a daily basis that is reasonable for the caregiver to provide and the patient to do, um, then it's going to be much less helpful. Just like, boiling it down to basic exercise for us, if we do exercise once or twice a week, and that's what we do, and the other 5 days we don't, we're never going to get the benefit out of it that we would if we did it 5 times a week. Again, realizing uh, we're talking micro doses here. If exercise were my medicine, and I talk exercise as global mobility, motion, that sort of thing. Um, Exercise being the medicine, we're giving it in doses that they can handle at times that they can handle. Your medications sometimes are 5 times a day,
Yeah.
right? Your medications are sometimes 1 time a day, right? And there's a reason for that. And so exercise is our medication, if you will. And that being dosed out properly is really important. And part of that dosing is daily.
Daily.
Yeah.
So
How
kind
can
of
you
so
find a way to do it, make it happen daily?
So I love this phrase that you use, movement is medicine, exercise is medicine. And I think how I'm kind of pulling this together in summary, as I'm thinking through this, and what I hope um, others will take away is that how you've said so many times, it's not necessarily these preconceived long sessions that we think of when we think of physical therapy. It's smaller doses, understanding kind of physiologically and cognitively what's happening in our patient, and then adapting those things. And even if we think, even if our patients get to a point where they're, let's just say they're bedridden, right? And so maybe we don't have that vision of what we think physical therapy is. A physical therapist still can help in manifold ways, whether it's, caregiver education on gentle exercises that can still be done in a prone position, proper moving the patient to help
And
maintain that skin integrity, how to help with, as you were saying, is some preventing of the respiratory issues. I mean, and this is just skimming the surface, but this is kind of how I'm processing through this.
I don't know that I could have said it any better. Um, that's what what we're here and what we do best. Uh, and and helping you help yourselves, and in educating you in those areas in which that we've talked about to help prevent um, a to help slow a decline that we know is happening, to help the quality of life during that time. That well, we know that's happening, and for all involved, and to help. And when I say independence and quality of life, I think for most of us, that's we tie those two things in together.
Yeah. Well, Rich, I think this has been a fantastic conversation. Your insights have been so valuable. Um, and I really hope that our audience is going to walk away really understanding the value of physical therapy in microgliopathies and how that kind of expands through the duration of the disease and life of the patient and caregiver. Is there anything else that you would like to share before we kind of wrap up today?
Oh boy, let me try and synthesize my thoughts here. I seek out physical therapy, be an advocate, uh, helping the therapist understand, and also being an advocate beyond um, what they may not be able to understand about what they can provide in PT
Hmm.
and physical therapy. Physical therapy is a 7-day a week process, and the most important time of that process is not when you're with the physical therapist, I like to say.
Yeah.
Um, do less at each time than you think you or the client can do.
Okay.
Um, save some in reserve. Does
Yeah,
that make sense?
definitely.
I think that helps in all ways. And remember, micro dosing of is important for activity, exercise, movement. Um, and I think that fairly sums it up.
That's wonderful. Well, to all who joined us today, I want to thank you for taking the time to be with myself and Rich as we have this very important conversation. We will be accepting any questions, follow-up questions that you may have, and you can direct them to info@GliaConnect.org. Again, thanks for joining us today, and we hope you found it helpful. Have a great rest of your day.
Thank you, Erin.